Hi, I'm Laurie Lebo, your host for today's Centerstone Conversations Grounded in Science. I'm joined by Caitlyn Placek, Associate Professor in Ball State University's Department of Anthropology and author of Drug Use, Recovery, and Maternal Instinct Bias. Katie has recently spent 6 months abroad as a recipient of the Fulbright Global Scholar Award to study the impact of cultural models of addiction and motherhood. Katie, you have just returned from Amsterdam and are back in the States and trying to catch up and analyze data. And I know that all of that work is fresh on your mind. So let's start there. Please tell us about that experience. Tell us about the award itself and what you did, what you learned, where you've been, and who you met, and all of the things.
Yeah, so first, thank you so much for having me. I'm really honored to be here. So for my Global Scholar Award, I went to Toronto in Canada, London, England, and then Amsterdam in the Netherlands. And I spent 2 months in each location. And my goal was to conduct mixed methods research. So the first part of the study, I did in-depth interviews with mothers in recovery, frontline workers, healthcare providers, and women without kids who are also in recovery to learn more about the landscape of substance use, recovery, and then the challenges that mothers face, and then some of the things that are working in each region to support moms through the recovery. And then in the second phase, I conducted quantitative research in two of the regions to test some of these models to look at recovery outcomes. So I'm still analyzing all of the data, but I can tell you some of the themes that I learned so far. So one interesting thing is that in each of the locations, one interesting and also disappointing thing is that stigma remains a huge barrier for mothers in all three locations in accessing treatment. But the way that stigma manifests and plays out culturally varies slightly between each of these places. So, for example, in Amsterdam, a lot of women talked about the pressure of being the perfect mother, led a lot of them to hide their addiction for years. So, there's a story that I heard of a mom who hid her cocaine addiction for 15 years, and people didn't realize it was a problem until she started having some psychological effects of the addiction, which impacted like her family relationships and things like that. Whereas in London and in Toronto, there was still stigma, but it didn't necessarily keep them from hiding their addiction from people close to them, but it kept them from coming forward about needing treatment for their substance use disorders, which is the same across sites. Also, the way child services is structured varies across the three locations. So in the Netherlands, they have a structure uh, that seems less punitive in some ways, and there's a newer approach that they're taking that's more of like a team-based approach to ensuring that both the mother, the father, and the children have all the support that they need during the time that say the mother is going through recovery. So there's a lot of structural and social factors that varied across the three sites. But I would say that the shared quality is definitely the stigma, which surprised me actually.
Wow, you having been in so many questions, Katie.
Yeah.
Having been in three different locations, were there unique challenges to each location, or was everything kind of cookie cutter the same as you arrived in each location? Tell us a little bit about that.
It was very challenging. So each place had unique challenges. So for each site, I had to get ethics approval before beginning the research, and I have my home institution. But for example, in the Netherlands, it took a little bit longer to get that ethics approval just because of the way that it's structured. But then once I had it, each of the recovery centers also had their own ethical clearance, which could take months to get. So I wasn't able to actually, so this is a limitation of the study actually, is that I wasn't able to go directly into these centers, which I was able to do in Canada. And in a couple spots in England, I was allowed to. So in the Netherlands, I ended up going to open AA and NA meetings, and there was no deception involved or anything. I just went in and said, hey, I'm Katie, I'm doing this research. Here's my information. If anyone wants to participate, you can contact me. And that was my primary entryway into the recovery community. But what I also learned was that a lot of people in the Netherlands go to South Africa for intensive residential treatment. So that also limited my research because a lot of people maybe weren't there physically to be able to participate. So a lot of the moms that I was in contact with were at later stages of recovery. And then in the UK, there was a lot of red tape around like detox centers and residential programs. So I also accessed people through like AA and NA, but also day treatment centers. So they had an open door policy where anyone could come in and come out. So I would do the same thing where I would introduce myself, hang out, and if anyone was interested, they could come find me or contact me to do the interview at a later time. But in Canada, once I got ethical clearance, I was able to attend a day treatment or a residential program and visit harm reduction centers. So each place was very different in the way I was able to access the communities and the types of services I was able to witness.
That's really interesting. And I think before when we met, you mentioned that could be another book. How to set up field locations, how to set up field sites in different countries.
Absolutely, because there's so many things you have to consider, not only ethical approval, but also building rapport with these communities, acknowledging that there might be some social factors, like you have to build trust, right?
Sure.
What I have to acknowledge that I am an outsider coming in, trying to research a vulnerable group. And so there's a lot of things to consider along that pathway and ensuring that you're doing it by maintaining respect for the community while also maintaining research integrity. So there's a balance that you have to strike between flexibility and also just being mindful of the groups that you're working with.
Yeah. If I remember correctly, before this, a lot of your work has been with middle to low income countries. Yet Amsterdam, London, Toronto, those are more high income areas. Why the switch?
So I made a switch because I had developed a project in Indiana on motherhood and recovery. And even though this is a high income country, the populations that I've worked with in each of these locations, they vary in their socioeconomic status and their access to resources and their access to recovery. And what I thought is that working in high income countries, we might be able to learn about like the different models that they have, especially in regions like the Netherlands, where they put a lot of effort into trying to solve their opiate crisis, which happened years ago,
Mhm.
decades ago. So I feel like we have a lot to learn from regions that are in a full-blown crisis or have done things to try to mitigate that crisis. So that's why I chose these regions, but also there is variation in access to resources. And here in Indiana, rural populations, even though it's a high income country, they still have significant barriers in getting treatment, such as transportation, being able to afford treatment, having the proper social support and being able to go to treatment while making sure that their children or their family members are taken care of. They have to think about their jobs. So a lot of the things that people experience in high income countries can be in some ways translatable sometimes to low and middle income countries, but also it helps us think about how these models vary in each of the locations and how we can learn from each other.
I love that. Um, I love that. I can't wait to be able to read everything that you learned while you were working in these areas. I know one of the barriers to receiving treatment is the fear of child services. Was that consistent across the countries? That fear, did you find any solutions to that in the different countries?
Yeah, I found two places that are working towards reducing that problem. So in Amsterdam, there was a fear, but it seemed less salient than the other places. And the role of stigma seemed less salient as well, even though they were still there. But in Amsterdam, it seems like the approach that they take, well, in some cases, it's still very punitive. That's how some women described it. But others said that, child services got in contact with them, and then they gave women ample time and support to get recovery. And they did what they could to keep the child within the family, which there are pros and cons to that. But they really kept like the family as like the unit of care rather than only thinking about the child. And it's very delicate, right? There's situations where the
Sure.
child does need to be removed right away, but that wasn't their first approach. And so that made women less fearful of reaching out and saying that they need help. Also, and I think one of the differences in the Netherlands is that the way they access help is a little bit different. So they go directly to their physician to say, "Hey, I'm having an issue with substances. I need help." And from there, their physician will refer them out to different treatment centers based on the severity. So they have a menu of options, which is really cool. So they're like, okay, well, is it severe enough that you need to go to South Africa? Is it fine enough that you can do this remotely and have telehealth as your option, and have some built-in systems at home that you can work with to help you with your recovery? Or do you need a 12-step program? So the way it's structured is very different. And so the first thing is, and in other regions, women didn't know where to go for help. And so sometimes they would first call child services, thinking that child services would help them. And that's not necessarily the role that they play when it comes to addiction. Their role is to protect the child, right? So I think
Right.
like the medical decision making is different, which also altered the role that child services has there. Um, and then in Northeast England, there is heavy child services involvement. And so there's a lot of grassroots efforts where women can come in for treatment, receive help that may not necessarily go to child services automatically. And I don't understand that process as well, but I know that it's something that they're working on to help serve as more of a mediating role, so that women have more time to access recovery rather than immediate child removal. So,
Did you find any in any of the countries anywhere, any women who created any kind of underground support system? Is
yeah,
anything like that?
I did. And I don't really want to say where.
Don't say where.
Yeah, but I did find that actually, which was pretty cool to witness. They meet on a regular basis and have formed these women's circles. Women refer each other to the center to say, hey, you should go to this place. Like they're going to help you. It'll help prevent child removal, things like that. And so that way women have other women that they can trust and rely on, which they all said was like really, really helpful in helping them sustain recovery.
That's great. Women are resourceful, right?
Yes.
Finding the help that we need. Your Global Scholar Award was not your first experience conducting research outside of the country. You also are a recipient of an NIH Fogarty Fellowship, which you went to India and studied in India for a while. Can you tell us about that experience?
Yes. So for that project, my goal was to look at gender differences in substance misuse among rural and urban populations, well, semi-urban. And so the rural population was an indigenous community in South India, and the peri-urban group was a mixed caste individuals like right outside of Mysore in South India. And the goal of the study was, yes, to understand gender differences in substance use. And something that was really interesting about this project was that in the indigenous community, the primary substance that they use, well, the primary two is alcohol and tobacco products. But the way that it played out in terms of gender was really interesting. So for tobacco, males were more likely to use commercial products, and females were more likely to use natural products. So they were working in tobacco fields, so they may pick tobacco and then dry it out themselves and chew it independently. And what was so interesting was that a lot of people talk about how males are more likely to use most substances or all substances compared to females. But here, the gender differences were, or there were no gender differences. They were equally likely to use tobacco, but the types of tobacco they were using were different. And this could have been based on just gender norms, but also the fact that substance use is more public for men and it's more private for women. So women might have felt safer using the natural forms because they could hide it more easily, whereas men could go to the shop and buy the commercialized versions and use it publicly with their friends or around anyone. Um, and then women also talked about how they would use the tobacco to self-medicate for low energy. So they were working in agricultural fields, uh, and they felt that tobacco treated their fatigue of doing that. And then my quantitative analyses for this part of the project also supported what they said, and that was that women who had low iron, who had increased environmental stress, so like occupational stress, and those who worked in the fields were more likely to be using tobacco. So, yeah.
Interesting. And you were able to document low iron through
Yeah.
biological methods, right?
Yes, I was taking finger pricks of blood to measure hemoglobin.
Okay.
Yeah.
Wow, that's tell me what was it like working in India versus working in London?
Wow, it's totally different. Well, I've been going to India back and forth for like 12 or 13 years, so I have more
Wow.
experience in India. So in a lot of ways, it's more comfortable for me to be there. Even though it's a non-Western society, I feel just very comfortable there. I'm used to it. London was a
Mhm.
lot harder for me because it's a bigger city than what I'm usually used to. And there are just different social norms, and being able to conduct this research. There are a lot more layers of bureaucracy, which India also has its own types of bureaucracy, but I think because I've spent years learning about how to navigate it, it was a lot different. But in India, for this Fogarty Fellowship, for a few weeks, I lived in the rural communities where the indigenous people stay. So I stayed in like a hut, um, on a cot for a few weeks, whereas in London, I was like in Notting Hill in a fancy apartment. So very different. I was able to eat the kinds of food that I wanted to eat. But it was a lot harder to build rapport because like when I'm in India, I'm surrounded by the community that I'm working with, and I'm able to learn so much more about the cultural and social dynamics. Um, so that was the difference. But also in India, there's like a language barrier, which I did start learning a lot of the language when I was living there.
Mhm.
Uh, but in London, it's so much harder to learn about some of the cultural nuances when the only access you have is through attending services. Whereas in India, I'm like there witnessing the whole cultural context. So
Right.
I feel like I'm a better anthropologist in India than I am in these Western societies.
That's really interesting. What a great comparison. Um, and great explanation of the differences and the challenges in both areas. There's not a tremendous volume of literature in this area, and you seem to be one of the leaders in cultural models of addiction and motherhood. In fact, have recently published your first book, Drug Use Recovery and Maternal Instinct Bias. Uh, and the research that you did for this book took place in Indiana. Can you tell us about that experience and about your book?
Yes. So I started this project because as a professor at Ball State, I wanted to involve my students in local research. So I thought, drug use in Indiana, especially among mothers, probably looks a lot different than it does for Indian mothers, particularly Jenny Kruba women who live in this rural region, right? So I wanted to try to understand some of those differences. And I trained as an evolutionary anthropologist, which means I use the theory of evolution to guide a lot of my research questions. But those theories don't really match up or describe modern drug use among mothers. So what the theory says is that females have basically an instinct, and this instinct drives a lot of drug avoidance and a lot of the lower rates that we see in modern drug use today. Um, but I don't really think that, I think that's sort of like, I felt like that was a bit of a bias. And I thought that, one way to test that is by looking at modern drug use in a population that has an opioid epidemic, because these drugs are a lot different than the drugs that humans had evolved using, because there is evidence that humans have co-evolved to psychoactive plant use. We have opiate receptors in the brain, these endocannabinoids. So there's biological evidence that we've co-evolved with these substances. So why do we get addicted to them? Why is it hard to stop? And particularly for mothers, if there is this maternal instinct, is it actually the thing that's driving them to quit using substances? So these were some of the questions that I went into this project with. But what I found was that it was really actually hard to answer the questions because I was only able to get 10 participants in the first year, um, which showed me that, maybe either they are using way less than I thought, or something else could be going on. And this is when I started learning about the role of stigma and how stigma prevents women from coming forward about their substance use, particularly in pregnancy. And I think that we need to be focusing more on stigma above all else right now when it comes to recovery, because that's the thing that's keeping people from coming through doors, oftentimes one of the main drivers. So anyways, through this research, I ended up expanding through my role as a program evaluator at Centerstone. I was able to access more communities within Indiana. This also helped me build rapport with them by, having this role as an evaluator, somebody who cares about their experiences and, wanting to accurately reflect those back to clinicians and the broader community to help destigmatize recovery. And basically, what I learned through that research is that maternal instinct does play somewhat of a role. I mean, it does. However, what women really need more than maternal instinct is support. They need support at the institutional level. They need interpersonal support from family members and peers. They need access to affordable services. Environmental factors such as COVID limited their ability to seek treatment. So a lot of the factors that go beyond the biological component of being a person or being a human or being a mother are these social, cultural, and environmental factors that are really necessary. And so that's what I broadly am thinking about, are these social and cultural factors that lead people into substance use and are what are helping them come out of it when they want to, but maybe don't know how.
I think there will be so many people who are listening right now who will be interested in reading your book. So thank you for sharing about it. Katie will be presenting her Fulbright data at the National Institute on Drug Abuse International Forum in Toronto next month. Get busy on that data, Katie. You've got a time crunch there.
Yes.
Please, I hope everyone will check out Amazon or your favorite bookseller for Katie's book, Drug Use, Recovery, and Maternal Instinct Bias. Katie, thank you for a great conversation. And to our audience, see you next time for Centerstone Conversations Grounded in Science.
Thank you so much.